Good afternoon or morning for some of you on other time zones. Thank you for joining us for Transplants 101, Introduction to Bone Marrow and Stem Cell Transplants. My name is Carrie Callis. I'm the Director of Programs at the Leukemia Research Foundation. This program today is being offered in partnership with the Blood and Marrow Transplant Information Network, BMT InfoNet. The Leukemia Research Foundation's mission is to cure leukemia by funding innovative research and to support patients and families. The foundation has raised over $83 million in support of its mission and has funded research grants to over 600 new investigators worldwide. Our free support programs for leukemia patients and their loved ones include information and resources, education programs, peer support services, financial assistance, and a directory of other helpful organizations and resources. Coming up in February and March, we're hosting 2 leukemia Q&A programs, which is all question and answer session of a panel of experts, which you will receive more information on through email, or you can register on our website, leukemiarf.org. Just a few quick housekeeping items for our program today. All participants will be muted throughout the program due to the large number of participants on the call today. If you already submitted a question at registration, please know that we have your questions and we'll get to as many as we possibly can. You can also type a question in at the bottom of your screen in the Q&A box. So the box you see when you scroll to the bottom that says Q&A, you can type your question in there and we will try to get to those as well. After today's program, you'll be sent a very brief evaluation through email, so please take just a moment to complete it so that we can improve our future programs. Also, this program will be recorded and sent to all participants. I would like to now introduce our program partner, Marla O'Keefe, who is the Director of Outreach at BMT InfoNet.
Thank you, Carrie. My name is Marla O'Keefe, and I am the Director of Outreach at BMT InfoNet. Thank you again to Carrie and the Leukemia Research Foundation for including BMT InfoNet as a partner in this important and informative webinar. For those not familiar with BMT InfoNet, we are a nationally recognized nonprofit that provides transplant recipients and their loved ones with emotional support and high quality, easy to understand information before, during, and after transplant. Our goal is to empower patients with credible information so they can take a more active role in decisions affecting their health and treatment options. It is now my pleasure to introduce today's speaker, Dr. Tulio Rodriguez. Dr. Rodriguez is a hematologist-oncologist specializing in bone marrow transplants and adjuvant health care. He has performed over 2,500 bone marrow transplants throughout his career. He has also published work and lectured widely on a range of medical topics. Dr. Rodriguez has devoted much of his research career to the study of hematopoietic stem cell transplantation and hematologic malignancies. Take it away, Dr. Rodriguez.
Thank you, Marla, for that kind of introduction. So let me share my screen. Hopefully this is going to work and it's going to go very smoothly. Okay. So can anybody corroborate?
Yes, we can see it.
Thank you so much. So thank you for the opportunity of offering this introduction to stem cell or bone marrow transplantation today. As I'm sure you all know, is a technique that provides an opportunity of a good outcome when sometimes other treatment options don't work as well, or take patients who have a high risk of not responding well to a standard therapy and bring the hope of a successful outcome. So the idea this afternoon is to provide some basic information, and hopefully we're going to set up a platform for discussions of your questions in special circumstances. Now, that being said, I want to make sure that we understand that what we discussed today is very general. and not necessarily applies to your specific situation or condition, and should not replace your conversation with your physician or provider. Now, so let's move forward. Yeah. Well, so everything starts with tumor growth. Doesn't matter what type of malignancy we are talking about. The tumor growth occurs either if it's a leukemia, breast cancer, colon cancer. You're going to have a cell that becomes a malignant cell and start growing excessively in the body. As you can see in this cell culture, by the second row on the first tile, that little arrow A is pointed to the first signs of a cell division. That if you follow to the left, you can see how there's like an appendix that is coming out of from that cell. So chemotherapy, what it does is that it's gonna stop the reproduction of these cancer cells, and they prevent these cells from growing and spreading in the body. Everything starts with this original cell that becomes a tumor. So now chemotherapy is gonna debulk or eliminate most of these cells, and that's kind of the problem, that many times after standard chemotherapy, you kind of leave behind some cells that can lead to the regrowth or tumor recurrence, expansion of that tumor growth. So the question here is, if that's the case, why we don't use a more potent medication? Why do we don't use a chemotherapy drug that can take or get rid of every cell? Well, what happened is that in the same way that there's a growth of tumor cells, there's some normal cells that they are sharing this characteristic. For example, in our blood cells, we all know that red cells, they have the function of carrying oxygen throughout our bodies, but they last in our bodies only 120 days. Right after 120 days, our bodies use the red cells, and they need to be replaced. Actually, platelets, that some of you might know, these cells, they work like the plumber's seal. They last only approximately 7 days. And the white blood cells, which are supposed to protect us from infections, they last 4 to 6 hours. So our bone marrow, through a process that is known as hematopoiesis, is responsible for the formation of all these blood cells from the hematopoietic stem cell that can be found in the bone marrow. So if we try to eliminate all these malignant cells, unfortunately, we're going to deplete our bodies of necessary cells that we need in order to survive. So as a technique to overcome this challenge, we have what we call stem cell bone marrow or stem cell transplantation. In this cartoon, the green side, the bottom part, is depicting what we it's a description of allogeneic stem cell or bone marrow transplant. In this case, you have the patient who is exposed now to a higher dose of chemotherapy, sometimes radiation therapy, and simultaneously, you have a donor that has been tested and HLA match and is serving now as an allogeneic stem cell donor. So through this stem cell collection or donation, now this patient can receive a transplant after having the treatment eliminating those cells that we were referring to priorly. So variants of this technique that sometimes is being used, for example, for other hematologic malignancies like lymphomas, multiple myeloma, the patient once has received therapy and the disease is eliminated from the bone marrow. Now this individual can serve as his own donor. So the collection of stem cells take place. In this case, because the patient now needs to go through the conditioning regimen, those cells needs to be put in a freezer, right, in very low temperatures in order to protect them from the higher doses of chemotherapy. But after the conditioning regimen, basically the same thing happens with all the cells, and they are transplanted. So these are the two main type of stem cell or bone marrow transplantation. But for patients with leukemia, more often what they go through is through an allogeneic transplant. So the bone marrow stem cell collection can be obtained in two main ways. One is the bone marrow harvesting, where the donor goes into the operating room and is put under general anesthesia. This is a patient on the prone position on his belly, and simultaneously, the surgeon and the assistant are going to extract bone marrow directly from the iliac bone. Right? So in this case, the procedure is performed sometimes in less than an hour. However, patients need to be exposed to general anesthesia. On the other hand, the peripheral stem cell, which is what you have on your right, it works by mobilizing the stem cells that you can find inside the bones into the peripheral blood. Once the stem cells are in the peripheral blood, they're going to be filtered through a machine that has like a centrifuge inside, and by density, we can select the stem cells, and the rest of the blood comes back into the body of the donor. And remember that in this part, the patient who is going through an autologous transplant or a stem cell donor who is serving as a stem cell for an allogeneic transplantation, they both can go through both types of techniques. Both of them, they have pros and cons, and some of them have been associated with better outcomes, faster engraftment. Some others are better alternative for certain diseases. So that's why it's so important to discuss with your bone marrow transplant provider what is better or what is best for your specific case. Now, what about transplant per se? Well, the technique has become more popular, and because it's more effective and safer. The truth is that the first time that a stem cell transplantation took place the way that we know stem cell transplant today was in the late 50s, early 60s. And I want to remind everybody that back then, not only the technique was in their first steps, but also the supportive care was not as good as what we have today. We didn't have the same antibiotics that we do have today. We didn't have some of the antivirals or antibiotics against viral infections. We didn't have these antibiotics against fungal infections. We did not know how to match donors so effectively as we do know today. So the treatment became less problematic. There were less challenges. There was more effectiveness, and something that was done only for patients with poor prognosis, a patient who did not have any other options. Today, allogeneic transplantation and even autologous transplant is being done for patients who are in better shape, patients who we believe they have a high chance of relapse, a high chance of having the cancer back. So we no longer wait until patients are sick or they don't have too many options to perform this. So the orange line, and for those who are not familiar with this graphic, remember that the horizontal line, what we are known as the x-axis, give us the year, right? So from 1970 to 2016, and then the number of patients is on the vertical line or y-axis. So the way that this works, when you have 50,000 patients, you throw a line that goes horizontally, and then when it gets interceded with the vertical line or intersect is when you throw a point. And the same thing continues over time, depending on the number of patients, and then you throw the line. That's how we know that over several years, the number of autologous transplants have been going up significantly. The same thing is happening with patients who undergo allogeneic-related donor transplants, and those who are recipients of unrelated, which basically is kind of a more novel therapy that has been evolving, and more numbers are being present nowadays. Now, the transplants, as I mentioned before, they have several indications. Here we have data from the Center for the International Bone Marrow Transplant Registry or research, and this is by disease. Again, on the x-axis or the lower line, we have the different type of malignancies, lymphomas, plasma cell disorders, or multiple myeloma, amyloidosis. We have AML, other malignant diseases, ALL, CML, etc. We have the MDS and the myeloproliferative neoplasms or diseases. The CMML falls in this category, aplastic anemia. Now, the color tells you the type of transplant that more often these patients are going to receive. So the orange represent autologous transplant. So the way to read this bar is that the patients with lymphoma more often receive an autologous transplant. Some of them are going to be recipients of allogeneic, and I can tell you that most of the time that happens when the autologous transplant doesn't work. On the other hand, patients with AML very rarely receive an autologous stem cell transplantation. Most of the time, they will be recipients of allogeneic transplant, and that makes sense in the case of AML. That disease is a disease of the stem cell per se. So using an autologous stem cell graft might not be the most effective way to do this type of transplant. So again, the two types of indications or diseases that receive autologous transplant more often, non-Hodgkin's lymphoma and plasma cell disorders, multiple myeloma, amyloidosis. On the other hand, leukemia, for the most part, they're going to be treated with allogeneic transplantation, either AML, ALL, CML, etc. Now, when we try to take someone into transplantation, when someone comes for evaluation, there are three factors that we take in consideration. Of course, we have in front of us our patients. So we don't treat myeloma, we treat a patient with myeloma, we treat a patient with AML. So I believe that this is one of the most important factors or in the process of making a decision about if someone needs a transplant or not. The disease is important as well because some diseases can present with high risk characteristics. That tells me if the disease is going to be resistant to therapy, or most likely, or there's going to be a chance of recurrence. And last but not least, the source of those stem cells that are going to use in the transplant. Are we talking about a donor that is a sibling, a full match, or are we talking about an unrelated stem cell donor that, as much as the technology tells me that they are identical, they are not really related by blood, so there's some minor antigens that are absolutely they're not going to be matched. And we also have performed some transplants using stem cell from umbilical cord blood, and usually this is done for patients who really need a transplant, but unfortunately don't have a donor, suitable donor among siblings or in the registry, right, for unrelated transplant. Remind ourselves that among the siblings, only 1 out of 3 patients who need a transplant are going to find a donor among their relatives. So these are the 3 important factors. And for example, if you have a patient who is in good shape, young, strong, no diseases, no comorbidities, and on the other hand, you have a disease that is very aggressive, and you have a donor that is a full match, and it's a sibling, that is a straightforward. We have the triangle that make me think, yes, this patient absolutely needs a transplant. On the other hand, if you have a patient that is very frail, is very sick, and you have a disease that has a low chance of recurrence, and I have no donor, I have to look for an unrelated or a cord blood stem cell transplant, I think that we'll need really special circumstances for someone serious to offer a stem cell transplant to that individual. So this kind of mind process help us to identify and select who will benefit for stem cell transplantation. Now, some risk factors for this transplantation, I mentioned the patient, disease, and bone marrow. Well, so age. Age has been seen that correlates with outcomes. The older the patient, the higher the chances of having more complications. And in some diseases that have been found even to be 36, 39 years old, like in the case of chronic myelocytic leukemia, in some others, 60 years old. Now, I have always remind residents, fellows, people who are in training, that risk factors like side effects from any drug is not there to refrain yourself from offering a treatment. Patients need a therapy. Those are there for us to identify those risk factors and to get prepared, to come up with a way or solutions to mitigate the risk, to know that the risks are there so you get prepared, not to tell someone, I'm sorry, go home because your age is prohibited, because there's not such thing as we will see shortly. Comorbidities is very important. Obviously, comorbidities that are not well controlled. So someone who comes with high blood pressure that is on medications and the high blood pressure is very well controlled, there's no reason whatsoever not to offer a life-saving stem cell transplant to that individual. Something that sometimes we forget, social determinants of health. What are those? Those are conditions that are not necessarily physiologic, right? So, but they have a very important weight on the outcomes of these patients. Do they have transportation? Are they depressed? Do they have this caregiver? So those aspects that not necessarily has anything to do with health, but they are extremely important at the time of the outcome of transplant needs to be evaluated in most transplant programs of quality are going to have a designated social worker who's going to be looking into this. They're going to have a navigator, coordinator who's going to be helping with this social determinants of health. As I mentioned, it is a high risk. Someone who's in remission, right? The outcome might be different compared to someone who you do a transplant in relapse or in refractory disease, where the disease is circulating to the bloodstream. And relapse disease, they don't have the same outcomes of patients who go into transplantation at the first time of their complete remission. I mentioned the source, autologous. I mentioned the age of the patient. What about the age of the donor? That is a debate. In some diseases, these have been found to be a factor, like in CML, for example. In some others, that has not been found to be important. And the other variant here is that when it's a sibling, the donor age is doesn't seem to be as relevant as when we're talking about unrelated stem cell transplantation. Now, the human leukocyte antigen match donor is important. Allogeneic related, unrelated, allogeneic related mismatch, or we call this haploidentical transplant, and umbilical cord. Now, graft versus host disease is a potential complication of allogeneic transplantation, can be acute, usually within 100 days, or chronic after 100 days. There can be some organ damage, liver toxicity. This is what we call as veno-occlusive disease. Infections, infertility is something important to discuss with young patients. That so there's some ways of trying to maintain fertility or to do some sperm banking, cell banking, etc. Secondary malignancies is something that we need to keep in mind. Alopecia is almost universal. And something that we want to maintain in our minds is that graft versus host disease is not always detrimental, right? So not everybody's going to have graft versus host disease, can be very mild. However, in some cases, it can be severe. The chronic graft versus host disease usually shows up on patients who had an acute graft versus host disease. But interestingly, with this graft versus host, which is the cells from the donor that are inflaming the body of the patient, the recipient, but this kind of inflammation, quote unquote inflammation, comes with a graft versus tumor effect. So what we have seen is that patients with chronic graft-versus-host disease can get cured from their diseases more often than when you don't have graft-versus-host disease. Again, doesn't mean that it's zero. And patients who have never seen GVHD absolutely can get cured from their diseases. But chronic graft-versus-host disease can bring an additional immunologic attack to the malignancy. Now, this is a graphic from the CIBMTR, or the Center for the International Blood and Marrow Transplant Research. These are the number of years from 2000 to 2020. Looked at peripheral blood stem cells is what have been done more often during these years. The blue part of the column means patients who receive bone marrow. So absolutely, when we're talking about MASH-related donors, more often they receive peripheral blood stem cell transplant. In the case of haploidentical, the same thing, but look how the number of haploidentical transplant continue increases over time, and they are significantly in higher numbers in 2019 and 20 compared to 2000. And again, more peripheral blood than bone marrow. Also, the same thing that happened with cord blood. There was kind of a boom in the cord blood. Remember that cord blood is a very small amount, so most of the time was done for children. We have done cord blood I have done cord blood for adults as well. But this is kind of a lacking popularity. It is kind of a difficult. The immune reconstitution, how these cells function over time, is difficult. I have seen patients with significant infections even a year later after the cord blood transplantation. And what happened is that the haploidentical transplants continue going up, as you can see here, especially in patients older than 18 years old. Now, this is kind of an important slide, and we're almost done with this part of the presentation, because I think that the most important part is the question and answer. But I think that it's important to demonstrate that from 2005 to 2020, the number of patients who are older than 65 years old receiving allogeneic transplant has increased significantly. This is expressed in percentages. So in 2005, only 4% of the patients, recipients of allogeneic transplantation for malignant diseases, were older than 65, in comparison to 27% of the patients now receiving stem cell transplantation. They are older than 65 years old, and this includes patients with AML, ALL, MDS or MPN, and lymphomas. Now, as I mentioned from the beginning, the technique has improved, and this is an alliance trial. That alliance meant that several group of researchers got together, put their efforts together, and again, in the horizontal line or x-axis, you see number of months, 12 months or a year, 2 years, 3 years, up to 5 years. The red line is the allo transplant. The blue line is the standard chemotherapy. And for patients, of course, in good shape, selected patients from 60 to 75 years old, transplantation does better than standard chemotherapy. So for us to tell someone that it's because that person is older than 60 years old should not get a stem cell transplantation, we don't know what we're talking about when we say that. Stem cell transplantation absolutely can offer a chance of a better outcome, again, for selected individuals in good shape, and this is, again, transplantation. If we look into multiple myeloma, and these are autologous transplants as we saw, if we take patients who are older, 70 years old or older, and the segmented line is patients who are younger than 70 years old. In this case, both of them goes into transplantation. You see the probability of continuing with a progression-free survival is identical. Doesn't matter if you're older than 70 or you're younger than 70. The same thing applies to survival. 10 years, the overall survival is almost identical between both groups. So for us, I can tell you that we have transplanted patients. The oldest patient that I remember in this institution, 83-year-old, and he's still alive, doing well. And he came with refractory lymphoma. That was like 3 years ago, and he's traveling. He's doing perfectly fine. So, in conclusion, bone marrow stem cell transplantation allows for the delivery of high doses of chemotherapy and or radiation therapy by replacing or rescuing the bone marrow that is being damaged by the necessary treatment. Now, the number of autologous allogeneic-related or allogeneic-unrelated transplantations in the United States had increased since 2000. The number of allogeneic transplant for the treatment of malignant diseases in patients who are older than 65 years old continues to increase. And in 2020, for example, 27% of allogeneic transplant recipients were older than 65 years old, as we saw. The use of reduced intensity chemotherapy or conditioning regimen or normal ablative therapy, we didn't talk too much about that, but for that, it's a less intensive chemotherapy, and of course, patients should be in remission. It's difficult to do a reduced intensity if you have active disease, right? But this was used in 60% of all the patients recipients of haploidentical transplant in 2020. And allogeneic bone marrow transplant, stem cell transplantation has the potential of reducing relapse rate and delivering superior long-term survival relative to chemotherapy in selected older patients with AML, especially those who are in their first complete remission. And with this, I would like to stop in order to open the forum for our speaker. And after that, I'll be happy to try to answer some of those questions. Thank you for the attention, and I hope you take as much as you can from this information.
Great. Thank you so much, Dr. Rodriguez, for that very helpful overview about transplants. And Dr. Rodriguez will be right back with the Q&A session. But before that, I'm going to go ahead and introduce Bob Trevor, who is a patient who has undergone a transplant, and he wanted to share some of his experiences and kind of what to expect with our participants today. And then immediately following, we will spend a little bit of time on the Q&A. So Bob, I would invite you to go ahead and get started. And okay, thank you.
Okay. Yeah, thank you. Thank you, Carrie. Yeah, and last week actually represents my 10th anniversary of the transplant, for which I am very grateful. So in 2012, 6 months before the transplant, I was diagnosed with aggressive AML with a FLT3 mutation for fast relapse as the cherry on the top. So I started my induction and consolidation with the chemo idarubicin, which I remember because it sounds like a woman's name, you know, idarubicin, Maisie Rubicin, whatever. And I did well. I did not have any kind of side effect, no nausea. I mean, I had tubes coming out of my arms. I had blood transfusions. I had platelet transfusions, but I was pretty good. And I was jolly. And in fact, I even made up a little song which entertained the nurses. Leukemia, 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 you're taking my blood cell and run Venezuela. Everybody, and it turns out one of my oncologists was Venezuelan. So they really appreciated that. So I go through all of that, kind of, you know, skipping through life and feeling fairly good. Then we find a donor, an unrelated donor to give me cells, stem cells. And I asked, look, can I wait a little bit? It's coming up to the Jewish holidays. I'd like some spiritual fortification before I get this transplant, because I know there will be probable GVHD and other things to deal with. They said, you're doing so well. Everybody agreed, go ahead. Go to services, get your spiritual fortification. I did, and 2 days after Yom Kippur, I relapsed. City of Hope has like a -4, -3, -2. At -2, they said, we have to stop this. You've relapsed. We can't give you the transplant, and we don't know how to get you back into remission. I said, well, I guess I'm not being written into the book of life this year. The important thing, part of this is you got to keep a sense of humor about everything as much as you can. I remembered a colleague who 20 years before had leukemia. I contacted him. He suggested I get to the Hutch in Seattle, Seattle Cancer Care. They had the most cutting edge leukemia treatments. The great late Elihu Esti suggested I get the G-CLAMS treatment, which is also known as the Polish protocol. This is verbatim. I'm not making this up. G-CLAMS is an acronym for 5 different very strong chemos. And the Polish part is they found 50,000 milligrams of statin has a way of socking the chemo in to fast relapse patients. So I went back to Seattle. Kaiser agreed to administer this chemo, and it worked. It kept me alive, except the original donor was no longer available. So they had to find a new donor. And in the meantime, they like removed my immune system, right? So anybody visiting, my very gracious and generous wife visited me almost every day. She had to wear a hazmat suit. I could not get any kind of infection, or again, it would be no transplant, and my chances of survival would be minimal. So it took another, I don't know, 2.5 months to find someone. And it was unrelated, as I said. Thank God for her. She was a young woman, ironically from my hometown in Philadelphia, as I later found out. So I got the transplant, the stem cells, and then it wasn't so much singing and dancing. It was tough. It was a tough road, but I'm very grateful to have gone through it. There'd be a bunch of us, apparently at City of Hope. Once you get the transplant, you have what we call the pagoda. It's like several layers of bags and stuff. Have I reached my 5-minute yet? And it was tough. But my tips that I can give you to those looking forward to it: if you're offered the transplant, get it. Keep your sense of humor whenever possible. Try to have somebody special in your life, a spouse, a good friend, to help you see it through with you. And one more tip, slightly off topic, but I think legitimate. There's a movie out called Living, which is, I think, critical for any person facing a mortal disease to see. Part of the message of this film, beautiful film, very quiet and nuanced, is do some good in this world while you can. And so I guess that's close to my 5 minutes. So there we are.
Thank you so much, Bob. It was so kind of you to share your experience and to give your tips, and hope for those on the call who are about to go through this or their loved one is. So thank you so much, Bob. I greatly appreciate you being here. So now I will ask Dr. Rodriguez to come back on, and Marla from BMT InfoNet is going to help facilitate the Q&A session.
Okay, great. Thank you. Bob, thank you for your story. And Dr. Rodriguez, thank you for the excellent presentation. We have a number of questions, so I kind of organized them a little bit. There are a number of questions on age. Someone asked if people over 80 years old can be transplanted, and if there is an optimal age for transplant.
Right. So most patients who are older than 80 years old are going to be recipients of autologous transplantation. Allogeneic transplants at that age sometimes can become challenging. But as I said before, this should not replace a conversation with your physician. There's some case reports of patients who have gone through allogeneic transplant at 80 and beyond. So it's not that it's unheard. That being said, it's not the most common type of transplant at this point in time.
Okay, thank you. How can family members test to see if they're a match?
Well, they can certainly go to their, usually we do that through our center. The National Model Donor Program has some events, and you can call them directly, and they can direct to the organization in your state. Here, for example, in Illinois, Life Source was one of the organizations that was kind of doing that. But in your center, sometimes they can collect the samples, and sometimes even with a mucosal brush is all what it takes.
And if a family member does match, what is a procedure for, how do they go about donating?
That is an excellent question, because something that usually happens once the sibling or family member is identified, they go through a workup to make sure that that patient is in good shape to donate, because many times it's known that the donor and everybody is kind of sensitive, and anxious about not receiving something or any transmission of infectious diseases. And of course, we all look for that. But something that we want to make sure that everybody out there understand is that the donor becomes our patient. And actually, we use a different transplant physician to evaluate donors, or a different provider. It can be a bone marrow transplant nurse practitioner, to make sure that there's no conflict of interest, right? That individual is going to be making sure that the health of that donor is the priority for that provider that is evaluating that donor. So the donor is going to be we're going to be taking care of him or her to make sure that both individuals and healthy.
Great. How is it determined whether a patient will be using their stem cells or a donor's?
So most of the time it's because of indications. Leukemias, for the most part, they're going to receive donor stem cell transplant. In very rare cases, a patient with AML and low risk, in some research, they have used autologous stem cell transplant, but that's not the norm. The norm is that autologous are reserved for lymphomas and multiple myeloma, while leukemias, they receive donor stem cells.
Very good, thank you. Is there any way, this is kind of a hard question, how is the success of a transplant calculated? We get those questions a lot at BMT InfoNet. I mean, is there any straightforward answer to that?
Yeah, because what the patient and I care about is survival, right? There's many surrogates, and institutions use engraftment on how many days the cells are coming up, and the patient can leave the hospital. That is a success, a transplant in the eyes of certain individuals. But at the end of the day, I want to make sure that the patient comes here and or come to any center with a disease as AML, as Bob mentioned. When I check on him a year later, he's still around, functional, doing well. That, in my eyes, is a successful stem cell transplantation. That's how you measure them. But again, yes, you can measure a success of transplants about how quickly they left the hospital, if they develop infections or not, how many transfusions they received, etc.
Kind of tagging along with one of your answers that you just gave, how long do patients normally stay in the hospital post-transplant? Is it a set time or does it vary? Yeah,
I mean, each individual is a little bit different, because I mean, some patients might develop some complications, even if there are mild complications, like I say, a mild complication, fevers, and no organism is identified. The patient just have temperatures, and that patient is doing well, walking around the unit, but you don't want to send that patient home if they have high temperatures. But in the absence of any significant complication, most of the time you spend 2 to 3 weeks in the hospital. We're talking about, in the case of multiple myeloma, 3 to 4 weeks when we're talking about patients with leukemia, for the most part.
Someone was asking about how the success rates of transplants have increased over the last 10 years.
Absolutely.
Yeah.
Absolutely. Every decade, and that's something that several institutions have done that. But Mayo Clinic, when they did a large analysis, especially with leukemia, every decade there's a survival increment. That being said, usually that happen in younger individuals, because those individuals are the ones that who go through transplantation more often. Fortunately, now we have patients with, as I said, 27% of them, even older than 65 years old, can go to transplant, and most of them, they do this effectively. Now, I don't want to minimize the advancement that have been achieved with standard therapy, right? We no longer have only chemotherapy. We have immunotherapies, etc., that are making an impact. But the bottom line is that, yes, survival continues improving, and it's not like it was 5 years ago. Absolutely not.
So it continues to get better. Are there certain qualities, I guess it would be like health or whatever, that would lead to the best results in a transplant?
Yeah, I mean, we use the triangle, or I use the triangle because I mean that's something that I just made up. But in my mind, the patient with a younger age, the patient with a disease that is in remission and a good stem cell source that have the better, the best chance of an effective and positive outcome.
You mentioned a little bit about graft versus host disease at the end of your presentation. And I know that not all patients get it. Are there some common signs of side effects? And is there treatment that, are there things that you can do to maybe help prevent or minimize it?
Yes. So from the beginning, I mean, we know that there's some risk factors. So depending on the age, the type of donor, the match. Some of us might use different approaches. For example, I remember several years ago using chemotherapy after stem cell was kind of a prohibition, right? Now, actually, cyclophosphamide, Cytoxan, has been used after haploidentical transplant because they have a high chance of graft versus host disease. So a few days after the infusion, you continue giving chemotherapy to this individual. Also, we have better drugs, and we have better drugs that have been tested in randomized tests like ruxolitinib or Jakafi. In the past, we were doing many things out of desperation. There was nothing better than steroids. People were even pushing for, I mean, nothing. So people were doing all sorts of things, putting central lines, extracorporeal phorophoresis. Nothing against that. Is that the data on that is very weak, very small numbers. Most of the trials were done in Europe. Most of those trials were using other drugs. Now we have drugs that have been tested in randomized trials, and they have shown significant benefit in patients with graft versus host disease.
Thank you for that. I have a few kind of more disease or diagnosis specific questions. Someone had asked, well, actually this one is, someone had asked, is there any data on transplant for Richter's transformation?
Yes. So it's not the most abundant data because Richter transformation, for those who are not familiar, is when chronic lymphocytic leukemia transforms into lymphoma. Right, so in chronic lymphocytic leukemia, we're talking about small cells that you might see in a follicular. A counterpart would be a follicular non-Hodgkin lymphoma, but in this case, these cells transform into diffuse large B-cell lymphoma, different kind of lymphomas. And at the beginning, people thought that was not even possible. But I can tell that I have seen biopsies in where you see the lymph node, and half of the lymph node is diffuse large B-cell lymphoma, half of the lymph node is CLL. So Richter syndrome does exist, but it's not common. And of course, at that point, they usually requires stem cell transplantation. Has been done. It has been done effectively. And especially for those who present with more aggressive disease, once they transform, usually that is the course, right? It's not going to behave like the standard regular diffuse large B-cell lymphoma. So yes, but again, this is not a replacement of your conversation with your physician. It's something that you want to discuss with your physician in detail as a general concept. Absolutely, stem cell transplantation has been done, had performed in patients with Richter syndrome.
Thank you. Another question along those lines. Someone had chatted in, they have a sibling with Down syndrome that needs a transplant. Is there any data on transplanting a patient with Down syndrome?
Yes. So, I mean, I'm very sorry to hear that. Leukemia in Down syndrome has been described. Many times we're talking about acute lymphocytic leukemia because it is being diagnosed in an early age, and that's what you see more often in children. But AML, acute myeloid leukemia, has been described as well. One of the problems that we were having with transplantation in patient with Down syndrome is that appears to be too toxic. And interestingly, some of us years ago we were thinking that liver toxicity was going to be the problem. Turned out that lung toxicity, pulmonary toxicity was higher than in comparison to other patients without Down syndrome. That does not mean that cannot be done. It's like I said from the beginning. Once you know what your side effects, you try to mitigate those in any way you can. Now, fortunately for ALL, and again, it's what we see more often. Now there's other options like CAR T cell. And again, none of these treatments, unfortunately, is 100% effective, but there is another option that we have for this patient, and there's an indication now for ALL. And in the first trials of CAR T cell, there were some few patients who were enrolled and they had Down syndrome.
Thank you. One last question. We have a time, I think, for a couple more. This is a vague one, generic one. Are visitors allowed in the hospital during the transplant process? Are the patients isolated?
No, visitors are allowed. Again, I know several programs. I'm not talking only on based on experience in my program. And visitors are allowed. That being said, my recommendation is to choose one individual or two individuals. The higher the number of visitors, the higher the chances of having some infection. We had a patient a few months ago that someone came on a Sunday, and then 2 days later, Tuesday, a friend, he called to tell the patient, I'm testing positive for COVID. Fortunately, we tested him and he was negative, but just imagine, and he was asymptomatic when he was visiting, but now multiply that by 12 individuals who come to visit you. So your chances are going to be higher. So yes, it is allowed, but I would strongly recommend you to select that single individual, no more than 2 individuals who take their precautions before come and visit you during that journey.
Yeah, that makes sense. Definitely limit the contact. All right, we'll make this our last question. It kind of ties into something you just said about CAR T therapy and transplant. Are they? Someone had asked about treatment for CLL. Do you do transplant first, then CAR T, or is CAR T something that's coming up, or what's the thought process there?
Well, right now we do our CAR T cell therapy based on the data that is available, based on what has been published. And in some indications, you can use CAR T cell after the first failure of your therapy. For example, that is the case of diffuse large B-cell lymphoma who fails stem cell transplant or fail first therapy within 1 year, right? In follicular lymphomas, if those are relapsing within 2 years also. So depends on the timing and how many recurrences or how many treatments that patient has required. So I can tell you that right now there's no CAR T cell approved for first-line therapy, that you are diagnosed for the first time and you receive CAR T cell. The sooner that patients are receiving CAR T cells right now, outside of a clinical trial, of course, because they are clinical trial for CLL, now they're developing clinical trial for AML. But as a standard of care approved by the FDA, you need to fail one regimen, and it's for the first salvage therapy that CAR T cells can be considered in diffuse large B-cell lymphoma. So that is something that absolutely you want to talk to your physician. Obviously, I always try to tell patients you need to empower yourself, and you look for yourself, and you bring your data to your provider, right? So I think that no one will be upset that you look for your data and you bring it for discussion.
Thank you. Carrie, I'll throw it back to you.
Great. Well, thank you so much to Dr. Rodriguez for taking the time out of his busy day to do this presentation for us. Thank you to Bob for sharing his experiences. Just a quick reminder about the evaluation we'll be sending. Please fill it out. It only takes maybe 1 or 2 minutes. And also we will be sending a recording and I'll try to link to some of the resources that were shared today throughout the program as well, just to be helpful. And if you have a question that was not answered, or really think that the Q&A part is beneficial to you of this program, we have our upcoming program in February and March, leukemia Q&A that you can register for, where we have a panel of experts and you can have your question answered there as well. So thank you all for joining, and you will hear from us via email here in a little bit. And thanks again, and thank you to our speakers. Bye-bye.
Thank you. Thank you.